As far as carfilzomib is concerned, it's really been shown to be an excellent proteasome inhibitor. One of the issues, I guess, as a prescribing physician is that a number of the different phase 3 clinical trials that have been performed use different dosing. So the original studies used twice weekly dosing at a 27 milligrams per meter squared. Other studies have used a 36 milligram, a 56 milligram, and then more recently there's been a 70 milligram per meter squared study. And what the ARROW study showed was that if we use once weekly dosing at 70 milligrams per meter squared and compared that to twice weekly dosing at 27 milligrams per meter squared, actually those patients on the once weekly dosing with the higher dose had a longer progression-free survival, better response rate, and also a better tolerability, suggesting that we can just use once weekly dosing, which is clearly more convenient for patients, but also it seems to be more tolerable. I think with all carfilzomib, we know there is a certain side effect profile. So unlike bortezomib, there isn't the peripheral neuropathy issue, but we do need to be a little bit careful with respect to measuring patients' blood pressures and also managing potential shortness of breath, which tends to be, if it's going to be an issue, tends to be an issue on that first dose. So just keeping an eye on that, but I think the data really is very promising for taking forward that once weekly dosing. One of the issues that arises from that is whether we can take the ARROW study data forward to some of the combinations. And I think that's a little bit unsure at the moment. So many of the combination studies that have been performed, such as with daratumumab or with lenalidomide or pomalidomide, have been using the twice weekly dosing. I think, this is a personal opinion, that it is okay to go forward with the once weekly dosing, but as I say, we don't really have the clinical data to support that approach at the moment.